repair it, and my goal expectation will be different because unfortunately your body type has a lot to do with how they're going to move them. So your length of your arms have to do with how you have to move them. And so, and then sometimes our patients come in and their body type is okay, and then they have another injury, and then they're in the hospital and they're sedentary, and then they gain weight, and then once again they gain, then we have to go back and to help them find that center of gravity over their body of mass. So I meant to go into that about these mechanical principles in a second, but first I just want to talk about, I gave you how to assess when they come in, to double check what sensory and motor they have. And those are the, once you find what motor they have, that's where you expound upon in terms of strengthening. Okay, so
I have a question.
Sure.
Sometimes it'll say in the doctor's note like they're C5 to C7.
Yeah.
What
That
is
means they're
supposed to
incomplete
mean?
and they
Okay.
have C, so when they do the
Oh.
ASIA scale, that means that they have C5, C6, C7 attributes. And so if you can test, you can say, okay, the right arm is C5, it has biceps. Maybe the left arm looks different, it's C7, and now I have triceps. So these assessment points can help you pinpoint what muscles they have. Because incomplete now, since surgeries are better and we're higher technology, we're not having complete injuries anymore. And we're seeing differences in both sides. That's why you can test to make sure. Okay, but on average, if you're C5, you have biceps, which anybody strengthens works on that. C6, we have wrist extension. That is the game changer for those folks. C7, we have triceps. So now I can really do really prop onto my arm and get some weight shifting going on with myself. C8 and T1, we begin to have the interossei, which is the muscles in between our hands. And for your person, they have some, but it's not always strong. So if I have someone that is C5, C6, and C7, who doesn't really have fingers, I am making sure, we always teach you in school, we don't want contractures. This is when you want a contracture. You don't want to overstretch the long finger flexors. So for the PTs who are teaching ambulation, for you guys who are moving, I sometimes wrap their hand in an ACE wrap, or remember them to keep their hands here, because if you stretch their finger flexors and they lose the tenodesis grasp, which is what is the big motor, which is how they grasp and release. So for those folks, and whenever you're doing transfers, you want some external rotation, you want their fist closed. Now there's a principle that we call muscle substitution, which you sometimes might have to see when you check. They may do this, and you think they have extension, but they don't. So you take them here, you block them, and then see if they can straighten. So what they're doing now is they're using pecs and delts to kind of go into this motion to be able to use gravity to kind of make them have extension. So you really have to check for that. So if they don't have that, what you can do is you can do muscle substitution. So I have them come out, block their elbow, and that's a pretend triceps. So if I say muscle substitutions, I'm blocking that elbow. So when I teach them to transfer, for those clients, fisted, external rotation, block if I don't have that upper body strength. Okay, so that's kind of the big thing here. This is for the OTs and PTs. Here for C4, C6, and thoracic, this talks about common goals for bed mobility, transfers, and wheelchair management and propulsion. And these are common equipment considerations for their house. So we have hospital bed, pressure relief mattress, power manual wheelchair, transfer board, mechanical lift, and so forth. I'm going to pass this out. Take whatever goals you want, but it kind of goes by the level of their injury. So there you go. I might be going fast. Tell me to slow down or ask questions if you have a patient in mind that you're thinking about. Okay. So any questions so far from what I've talked about? No, good. Okay. So, this is another thing. So I mentioned to you that we want to keep tight finger flexors. For you PTs, we want to keep loose hamstrings, because if they do long sitting or transfers, they have to have that flexibility. So these are critical range of motions you need to have for upper extremity and lower extremity. So I'm going to pass this out for you guys to have. But you guys know how to do the hamstring stretch, right? Where if their hip is up, that means they're not really stretching their hamstring. Keep their pelvis to the mat. And again, everybody's different, so that's what we have to look at. Okay. All right. So No questions so far. I'm just kind of running along as I'm talking about these information. Do you think of any patients? When your patients come in, what are some goals that you have? And I'll kind of continue on with them.
Bed mobility.
Okay, so bed mobility again is what muscles they have. So if I am a para, right, I should, and let me show you, I should be able to use my arms or to help get myself up. So let's talk about, so one thing that a para could easily do is if they can't, they should be able to get up the para, I think. They use your arms, come up, push up. The ones at the higher cervical level, we may do, which is a principle called momentum. So let me pass this out and we'll go through this PowerPoint, which is mechanical principles for spinal cord injury. And this is kind of answering your question, how do I get better bed mobility? And I hope I have enough so I can talk to it. There you go.
I think that's all of them.
Perfect. Okay. Oh my gosh, my eyes are so bad. All right, so okay, the first two slides kind of talk, which I think are pretty intuitive. This is more for my students. Giving positive feedback, encourage, repetition, blah, blah, blah. Let's go to the second page, page 2. So when we think about their goals for bed mobility, for transfers, we need to talk about these principles. So I already talked about the impact on body type. Length of arms, premorbid weight, shoulder girdle integrity, and hamstring length. So sometimes we'll teach our clients who can transfer to do popovers, sometimes a long sitting transfer, right? Sometimes a slide board. Are you guys familiar with teaching those kinds of transfers for?
I don't know what a popover is.
Okay, so if I have pretty good triceps,
Okay.
I'm in my wheelchair, I can basically pop over to the thing right there.
Okay.
Yeah, and then when we talk about transferring, we always think about, can they transfer on an even surface? So am I transferring on the same level, or is it an uneven surface? And of course, obviously, it's harder to transfer to a higher surface. So if I'm teaching transfers, then I'm looking at what surface do I want to grade it at to make it easy. So,
So
okay.
someone with a C7 would be not expected, but like would probably be able to do a popover.
Depends, right, on their body type,
Okay.
on how strong they are, on their arm length. They definitely could do a slide board, for sure. And then popover could be on a higher level,
Okay.
yes, yeah. But I would still have a slide board because even though they have triceps, they fatigue. So you want to have another way to be able to move besides a popover.
Okay.
Popover is really good for like your paras. The ones that are higher sea levels, they'll fatigue, and even though they're strong, they're not as strong. And then again, that's the body type. So, okay. Shoulder girdle, we're looking at their integrity. Do any of your patients are coming in with shoulder pain? Okay, so high incidence of carpal tunnel, rotator cuff issues. Do you know what kind of injury they have? Or what's going on with their shoulder?
It tends to be like with Bill, it's, I think, arthritis and just like,
Just general, yeah.
like overuse, maybe some arthritis, but
So is he able to protect his shoulder, or what are you guys doing to kind of address those shoulder pain?
I tried to do, he has really good range of motion.
So when he does this, there's no pain when he comes, his shoulder flexor abducts?
It's only with repetitive movements that it starts to hurt.
Okay, does he use a slide, how does he transfer over?
Where,
Okay, so he doesn't, so when does he use his shoulder?
just for like bed mobility stuff, moving around, if we're doing strengthening, there's only so much we can do before it starts bothering him, so.
So describe to me what bed mobility is can cause shoulder pain.
He uses his arms a lot to like push up onto his elbows or to like grab and hoist himself over.
Is he a big guy?
He's
Yeah.
huge.
Okay, does he have a bed cane? Does he have any adaptive equipment for his bed?
Yes, he has at least a rail.
So he has like a bed cane thing. Does he just use it to kind of roll over? And then, because if his shoulder's not above 90 degrees, he should be protected okay. How does he look when he rolls over that's causing shoulder pain?
I don't think it's rolling in particular unless you've seen something that I
I
haven't.
guess I mean like weight bearing.
I was gonna say, he was bothered by it the other day when he was like trying to push himself up.
Oh, okay. So when he's pushing himself up, is he externally rotated a little bit? Does he? What level of injury is it?
T something.
T8. Okay. So he has full upper body. Does when he pushes it up, is it? How does he get up? Is he kind of externally rotate? Is it kind of a weird, not biomechanically good way of pushing up?
I feel like he doesn't think he needs so much help with it.
So does he have a?
He doesn't sit up on his own.
He doesn't have trunk control.
No.
I think it's
Poor.
not strong.
Poor. Okay.
It's almost kind of like
He's
upper
usually like
trunk.
always
Yeah.
supported somehow.
Okay. Will probably being a big guy and so forth.
Mm-hmm.
Okay. So he probably just needs something around, I guess, other ways to push himself up besides this, if that's what's hurting his arm. That's what I'm hearing you guys say.
Yeah, I don't know what the cause of his shoulder pain is, but
He had it before.
Oh, premorbidly, he had shoulder pain. Is he having it seen by someone?
Not to my knowledge.
Is he tight anywhere?
No.
So he's good external rotation?
His range of motion is like almost hypermobile.
Do you think it's like instability or impingement?
Yeah, do you think? I would think impingement, like if he got to a certain thing, right? He would
Or
feel
yeah,
pain.
because this
But
guy
if he
for
is,
example.
does he need to strengthen his scapular? I mean, I'm not sure if he's, like if he is unstable.
believe
He's
that.
weak. I could see that there could be instability.
It's also just hard to tell because
And
he
like-
is such a big guy
Yeah.
that like
When we first started seeing him, like he was uncoordinated.
Like he had some ataxia? Okay, is there a cerebellar stuff? Okay. All right. Maybe, okay. Is he still ataxic?
It's gotten better,
Oh, okay. All right.
but I don't know. I was
So-
surprised to find out that he was a T8.
He just seemed lower.
Mm-hmm.
Yeah. I mean, I guess for his, and I have some pictures here, wherever you find those repetitive things causes a shoulder pain, I would problem solve, which is a lot of times spinal cord injury is problem solving. What can I do? When do you do this motion? If it's in bed, do you have the bed cane to kind of not, to not put the exertion forces on there? I do have, which I didn't bring with me, it's an evidence-based shoulder prevention and working with shoulder pain exercise program. So if it's called Stomps. If you're interested in that, it might be something to help him. But I don't know why I didn't put that out, but I can email it to you. And so, okay. So let's go back to here. So a lot of times with your spinal cord injury, it is kind of problem solving together. Because I jimmy a lot of things, which is why I have all this stuff here. Okay, so we have muscle substitution. So we've got to figure out with him, and maybe it's just arthritis, so it's just trying to protect his joint. So any joint protection, who's the OTs in here? So, okay, so joint protection types of strategies for him. Momentum, and then head to hip ratio. So when we're talking about bed mobility, mostly for my lower level, but you could use it anybody, when they get up to eventually from laying down, we'll do a lot of rocking. I don't know if, and then once they're rocking, that momentum helps to then get them onto their elbows, right? And then they kind of extend their elbows, and then if this is lower level, they might scoot themselves. So momentum is always an important thing when moving our clients. So I'm not sure with him if he's just,
I get it. So part of the problem is he has a fused hip
okay.
on the one side on his right. But I taught him head hips and
Yeah.
active scooting for because we have a goal of getting him to be able to slide board transfer. But I mean, he can do it, but again, he fatigues quickly. He can only get a couple scoots before he's gassed. But he can do it. And it's poor to the side.
Yeah,
with
because
fused hip.
does he think he had his diet or anything? Or to help?
they have him on a diet now. He's telling me they're like
He looks like
doing
he's lost
like
weight to me.
portion